Well, folks, welcome to Healthcare Unfiltered. And I've said many times before, the reason we do this show is for patients, caregivers, and for everybody else involved in healthcare. But the ultimate, quote unquote, end user is really the patient who really uses healthcare. And I have the pleasure of having two friends, but they are in they're a patient and a caregiver, basically. And we're going to talk about the cancer journey that they went through because the more I learned about some of the struggles that they faced over the past 1 to 2 years, the more I felt that these struggles should be shared with broadly with a lot of folks. And more importantly, maybe there's a way, maybe there's a path forward. Maybe there are some lessons learned that we can actually all work together on making things better. Sometimes I feel like I sound like a cliche when I say that, but I really believe that the more we know about the problem, maybe at some point we can find a solution. So, John and Heather, welcome to the show. Welcome to Healthcare Unfiltered. It's your first time on Healthcare Unfiltered. So, Heather, you need to play your cards right to be invited again.
All right, Shadi, we'll try to do that.
So,
It's great to be here.
let let's just do an introduction just as to who you are, like, what do you do professionally, and I know that obviously you have some medical background with Heather and things like that. I think that's really relevant to the conversation we're going to have.
Yeah, go ahead.
I was a lawyer by training and practiced law. I morphed my way into a career in finance and ended up as chief financial officer of an S&P 500 company and then CEO. I retired and got interested. I was looking for something to do because I'm married to a younger woman who didn't want to retire and moved to Florida. So I was looking for something to do, and I got interested in teaching. I have an MBA from the University of Chicago, and I was able to use my MBA to get a job as a lecturer at the University of Kentucky teaching investments and finance. So I was 73 years old. I've been teaching for 7 years, and when this saga unfolded, I was 73 years old.
I do feel I need to have another episode with John just about investments. Now I'm like, okay, let me just take notes which stocks I need to buy.
Right.
Yes.
No, thank you for coming, John, on this is very important. Frankly, one of the things in terms of your background that's really important is that you're very educated, you have advanced degrees, and you obviously are connected. And that's going to play relevance into the conversation we're going to have because despite all of this, it was not smooth sailing for you. Heather, how about you?
Well, Shadi, as you know, I think we go way back. I was a resident, you were a fellow. We had a friend in common who was a drug rep, and I don't know what happened to our friend, but we've stayed friends. So I think she got upset when I asked her to be a bridesmaid at my wedding.
Oh boy.
Maybe it was the dress that did it. But no, you and I probably have I don't know, 25-year history if we think back to those days. And I practiced medicine for 17 years. I did an MBA, worked in 3 startups, and I went to work for a large medical device company where interventional radiology was an area that I focused on from a consulting standpoint. And more, I was fortunate enough to be selected to be in the data and AI team by the chief data officer. And that led to opening my eyes to what AI can do beyond what we can see on images and how pixels are so important and patterns can give us so much information. So stepping aside from clinical practice and surgery, I now focus on AI. I've worked also at Blue Cross Blue Shield in using AI for provider burnout, and then in the advanced visualization space, and I'm currently working at Philips. So
I didn't tell you this, but I'm going to interview separately for my third book that I'm planning on writing.
okay, which one?
If I ever get a publisher. So, John, I know that this may sound like a cliche question, but it's honestly not because I think we all feel we're invincible until we're not, until we really get a threat, and nothing is really more threatening than our health. Take us back through how did this come about?
Well, you're 100% right, Shadi. I would have told you, and as a 73-year-old, I was invincible as much as 73-year-old can be. I've been a runner my whole life, and had graduated doing other kinds of exercise, including swimming and biking, um, and am a very active person. I've never smoked, drink very, very sparingly, never done drugs, never vaped, never smoked marijuana. Um, so when a nodule, and I do have a heart device, one in 2018 when I was 68. I was diagnosed with cardio
Hypertrophic cardiomyopathy.
hypertrophic HCM, hypertrophic cardiomyopathy, and so I have a defibrillator pacemaker combination. And I got a scan, a CT scan, related to my heart at a time where I thought I was suffering heart palpitations. And and they discovered a nodule in my lung as an incidental finding. So the words incidental finding are, I think the road to hell is paved with incidental findings. I did not take it seriously whatsoever. I just thought, oh, this is just one of those things, nothing really. How can this affect me? I've never smoked. I've never been around secondary smokers. I've never been exposed to asbestos. Worked in a nice, beautiful office my whole life. Really, I was, and so, I sort of got around to going, and the follow-up visit with a pulmonologist that Heather came to with me. And I would say, and just to reaffirm what you said in your introduction, we're blessed to have advanced education, good jobs. We are well-to-do, let's say. Our insurance is the best you can get. I don't even want to tell people how well we do with our insurance. And I'm married to someone who's a physician that has an intimate knowledge of the healthcare system. And as she reminds me all the time, she's not an oncologist, but she knows she's starting a 100-yard dash at 50 yards, and all of us are running 100. So there's a huge difference. So I go to the pulmonologist, and I should tell you a little more, and that is that I came of age. I was educated at the University of Chicago, and I know you work there as well. And probabilistic decision making is something that is preached at the University of Chicago, data-driven decision making. And so one of the things was, we went through the probability analysis of whether the nodule was cancer, and decided to not do anything, to just observe it. And that was completely consistent with my desires, because I just couldn't believe it was anything. So we decided on what, a 3-month interval,
Yeah.
3-month interval, and then 6 months.
So Shadi, I thought he was having aortic dissection from the symptoms he was describing. So he went in and he had a chest, abdomen, pelvis CT. And so as we're leaving, they pull us aside and say, oh, by the way, there's a 9-millimeter spiculated nodule in your right lower lobe. Okay, so I know that sends my radar up, and the next day I'm trying to find out about how to get into the lung cancer screening clinic. What happens next? And so you go through this, oh, but you don't fit the criteria. Well, but we got this diagnosis, we'd like to work it up. When we finally, a few weeks later, get in to see the pulmonologist, He doesn't want to do a PET scan. He wants to observe it because he doesn't have a prior, and John's prior was 2010. So the lesion wasn't present at that time. So we got a second opinion. And because, again, the latent period since the last scan, we didn't, everyone was comfortable with a 3-month window. So that's where, just to let you know, we didn't sit on it. We
Yeah.
acted.
And
But
your advice that, we just have to monitor every 3 months and we will intervene if we see a change in the size or something like that.
Yes,
Mhm.
exactly.
Yeah.
So
How long does this waiting period go for?
first 3 months, no change. In fact, it might have even decreased. And then we decided to go 6 months, right?
Well, at the 3-month scan, it was read as having been several millimeters smaller. And that was 9 millimeters. It was a saucer shape and it was spiculated. My experience sent up red flags, but everyone that was involved in the care cycle was, okay, it looks like it's smaller. And I think the mistake was the pulmonologist pushed this next screening scan to 6 months. And I was tied up with my elderly grandmother who was having some health issues at 95. And so John went to that appointment on his own. And then, we were in Argentina for a while over the summer. Things just happened. And then I said to John, well, when is your next scan? And so I thought it was a little bit long. And in retrospect, we should have pulled it forward. But his last scan was October 12th of last year. And this was the scan where the pulmonologist comes in the room and the coat is flying behind him, sort of like he's in a hurry now to do something. And what was so interesting is the thoracic surgery. You learn about the different schools of thought and approaches at institutions, and the lung nodule program managed by pulmonology versus the lung nodule program managed by thoracic surgery. And so when we came home from that appointment and they said, okay, now we have to do a biopsy, we'd been for the second opinion, and the thoracic surgeon at another institution where he ultimately wound up having treatment, he said, I wouldn't biopsy because you're at the fissure line and you'll develop a pneumothorax. And I would just do a segmentectomy. And I think, Shadi, you and I communicated about this during that time. But when I came home from that appointment last October, I called the thoracic surgery office and they actually said, we could see you tomorrow. And, it was that department of Northwestern is just incredible. I mean, every experience we've had with thoracic surgery has been fantastic. And so
that's
then
when you went back to, so it grew in size and
it grew.
and they decided to do an intervention, which was,
Yes.
so basically, I mean, initial observation seemed to be appropriate, and then, let's just do something because it has gone in size. And then you went to the thoracic surgeon, and that's where they decided we're going to do a PET scan and surgery after that.
Yes. So originally plan was a segmentectomy. We had to get on the schedule for the PET scan. And so in the intervening time at the other institution, they had scheduled for interventional radiology biopsy. And I think, I said to John, well, just leave it. You see what the guy says. I don't think that we're going to go that route. But it was really interesting. I think you could describe your feeling then.
Yeah, so I had a call with the I was referred to as Heather said, interventional radiology at institution number 1. And they were describing how they would do the biopsy.
The peripheral.
And the first problem was that I wasn't assigned to a specific doctor. They said, basically, this is a minor procedure. You'll be assigned to who's ever on call that day. I'm doing your pre-op. I'm just doing your pre-op consultation. I'm a gynecologist.
I mean,
Gynecologist or anesthesiologist?
interventional interventional gynae.
Yeah.
So
Yeah.
I specialize in gynae procedures.
Yeah.
That's it.
All
fantastic.
right. Well, I mean, John
Yeah.
seems very, I mean, I don't know, what's you're
Yeah.
complaining about? Seems like a
Yeah.
gynecologist is the right person to take care of
Yeah.
this.
And it just sent, I mean, you weren't on the call, were you?
No, but you had it
Yeah.
on the speaker, so I heard.
Yeah. It just sent red flags up, no doctor assigned that we're going to do this biopsy. And by then I had been educated by talking to our second opinion, which was at another institution, at Northwestern. And and I think you did your fellowship at Northwestern,
Yeah.
as I recall.
Yeah.
So, I had gotten to them, and one of the things that the thoracic surgeon had told me was I wouldn't do a biopsy because this is too small, and the shape, and we have the problem of being at the junction, but also the shape is very
Yeah.
unusual. It's like a flying saucer shape, and it's going to be extremely difficult to get a meaningful biopsy of this. So
What
his recommendation was segmentectomy.
in my book, as you know, that you both are reading the cancer journey, I have an entire chapter on second opinions, and it
Yes,
seems like you
I read that
obviously
chapter.
dealt with this. What, from a patient perspective, what do you tell people and that sometimes get worried that if I get a second opinion, I'm going to offend my doctor or something like this? I mean, what are your
Well,
thoughts?
yeah, well, you're talking, I grew up in the finance business, and we don't care about what people
Yeah,
think.
yeah, you're cutthroat. I know.
Heather grew up in the physician. She doesn't care. We both believe that's a search for truth. We're all looking for truth.
I think
And I think you absolutely, every patient for something that's serious, I had always had it in my mind. If I ever had something serious, I would get a second opinion. I don't care who's offended. And I would go to find the best doctor in America that I
I'm totally with you on that. I feel that, and that's honestly why I dedicated an entire chapter to it because I'm a firm believer. Heather, you're going to say something about that.
I think it becomes very important, and what I've seen with John, going back to when HCM was relatively unknown, to now, is you have to be your own advocate, and you sometimes have to be somewhat unpopular in the requests that you make and the decisions that you take, because there is a fundamental problem with access. And as physicians, everyone is overloaded, and you're in many cases a number. And I think the second opinion was really helpful because from the time we met this physician, he was actually the reason that we didn't pursue treatment at MD Anderson. And it was a very personal connection that you felt like, or we have felt through the entire journey with him, that he's had John's best interest. He's been the type of physician that you and I were, that you would call your patient. He'd get the CT results and call. And we planned out so John could finish his teaching. It was like another 2 weeks from this October timeframe that I spoke about before. And we were going back to Chicago, and he was scheduled for a PET scan and then a segmentectomy. And that evening he called and he said, I wanted to let you know the PET scan shows that this is locally metastatic. You have 2 lymph nodes that are lighting up. It's still contained to the lung, but we're not going to be able to do the segmentectomy. But I've spoken to my colleague, the interventional pulmonologist, and he's going to take the OR time tomorrow. I'll be in the OR with you. I just won't be doing the procedure. And then we'll have to talk about what we do once we get this biopsy result back, because the picture has changed based on the PET.
Right.
But he was there to do the hand holding and the transfer, and the next morning at the hospital, the interventional pulmonologist comes in, and it was just seamless. And that's the way, that's his philosophy of practice.
Right. So then you went through the biopsy of the lymph nodes. These lymph nodes came back positive.
Well, I think there are 2 good things that we could tell, I think, ask people they might consider and take away from our experience. The first thing is, I'm again a believer in probabilistic decision making, but the fatal mistake I made in observing was not answering a question I often ask myself in my professional life, which is, what if I'm wrong? Because had I had the segmentectomy immediately when it was first seen, and there are many people that would have heard the word possibly cancer and just immediately opted for, oh, cut it out. I don't want this thing in me. But I was in such denial that I just thought this can't be cancer.
But you did not, in fairness to you, you did not ignore it. I mean, it's not like, you said it wasn't cancer and you just
but we
went.
were on the waiting, the problem is, and we can tell the rest of the story, but so this is a little bit of a presaging the rest of the story. But the problem is that had I done the segmentectomy immediately, my life would have been so much easier in terms of treatment.
Why is that?
Having waited, I had to have a lobectomy, and that triggered, and because my lymph nodes were then involved, that triggered a whole additional range of treatment, including chemotherapy, and then, as we'll tell you, alectinib. But so I think asking, getting a second opinion is good. And when we got the second opinion, the doctor was extremely careful to say, you could, deciding to proceed and watch is a reasonable course of action. It's not wrong. It's reasonable. But my recommendation is you should have the segmentectomy. And I interpreted that as, okay, I can make my own decisions. And I had my wife there.
Right.
And so we decided at the 3-month mark to wait.
Right.
And so that was a fateful decision. The second thing I just wanted to bring up is, because I've read a lot about people that had this experience of having the biopsy and waiting for the results. We had the biopsy, and again, it was seamless. But of course, maybe you can, I don't remember exactly how the results came, but we were having them genomically tested.
Yeah, so
we had a long wait.
These were the things that I think probably we wish we would have known a little bit more. And I think your book does a good job on this, but the field has changed. And when you and I trained, we had small cell, non-small cell, we had EGFR, maybe CRAS, but we didn't have all of these genomic driven lung cancers. And so the field is evolving very rapidly. And we were waiting for the biopsy, and I don't think we understood exactly how long the genomic portion would take. And the interventional pulmonologist called us a week after and said that they were close to getting the results. And he gave us the PDL1 percentage, and yet the other composition was still to be determined. Then he said, I'm going to present you at tumor board next week. Okay, well, that causes a flash in your mind. And
why is that?
Well, you start to think about when you bring together the multidisciplinary team, it's no longer a straightforward problem.
Or it could be their standard operating procedure.
It could be, but it's just, it was a little bit unnerving.
Yeah, that's why I asked you, because whether it is standard operating procedure or it is convoluted, on the patient and the caregiver perspective, this implies that is this more serious than we thought it was.
That's exactly what it implies.
Yeah.
And then also when we got the results, and RSNA is a big part of the healthcare community. And so I had just finished giving a speech at RSNA Wednesday, the last day of the show, and I came home and I find Jon just sobbing uncontrollably, telling me that the thoracic surgeon had called. He has this type of lung cancer. I immediately started going to PubMed and pulling articles and trying to read about what was ALK positive lung cancer, because it didn't exist back in the world where I was practicing, and it wasn't a focus of mine. So we started to do some research and read. And then, really it was 2 weeks of waiting for the biopsy. So we waited over Thanksgiving.
Let me just interrupt. I'm sorry, sweetheart. We only waited 2 weeks.
Yeah.
And this comes back to, again, your initial introduction. We are very well connected. We got very fast treatment. We've heard of situations where people wait 6 weeks. But one of the things I would say, and you're very nervous. I mean, I was very nervous. Heather was very nervous. And you don't know what to do until you get these results. But the one thing I would caution your listeners is you just have to wait. And my advice is the best thing you can do is just don't do anything until you get those genomic results, because the course of treatment is dictated by those results.
Yeah.
And anything else you do in the interim, which I have read again in the Facebook group I'm in, I've read of people that insisted they start immunotherapy or insisted they just had to do something. That's a bad idea.
But there is that sense of being extremely helpless. Like each day goes by, every hour seems like a full day when you're waiting for this, because, your life hinges on what happens next. And so is it chemotherapy?
Do you think the doctors or the team could do what could they do during the wait period? Because obviously from a patient perspective, like Jon just said, waiting is important because you want to know the information, because the decisions based on that information, there's no question. There's this anxiety. Every day is like 7 days. So what could we do during that wait period until the results come in that could mitigate some of these sensations that you're having and feelings you're having?
Yeah, and I think there are two things. One is I think I have the greatest respect for the doctor that did my biopsy. I mean, he followed up immediately. Everything was perfect in that regard. But probably he wasn't clear on how important this was to my treatment, and how important it was to wait. And the second thing was we didn't really understand how long the wait was. So we were, every day for us, we were like, oh, have you looked at my chart today to see if we got the results? I think that some degree of hand-holding, I think we are sophisticated consumers. If you probably shouldn't call
I think, Shetty, you were holding my hand through this, but from a structured standpoint, there isn't a nurse navigator or a physician extender that helps to guide you through. You're sort of waiting for that phone call of how's the rest of my life going to go.
Yeah, you know what I think could be done? I mean, this is just, I think it's about communication. I think there are two issues here. Number one, like you both said, it wasn't really clear how important these results on the treatment. And number two, probably the expectations were set too high that you're going to get the results fast. So the hand-holding is really key, whoever that hand-holder is. So sitting down and say, look, these results are important, but I promise you that these 2 weeks are not going to be detrimental to your overall health. Just getting that reassurance, that waiting, because usually the anxiety piece is twofold, right? One fold is what am I going to do with the results in terms of treatment? But really the undercurrent of this is that wait going to affect my outcome adversely?
Exactly.
Yeah.
That's a very
exactly. And consider, I mean, we were blessed that we only waited 2 weeks.
Right.
We know people that waited 6 weeks.
Yeah. So let's move on. Now you got the results. You have the results. It is ALK positive non-small cell lung cancer, and you were offered a clinical trial. I'm very, very curious about your experience into getting into the clinical trial. There's a lot of we all know most patients don't get into clinical trials for one reason or another, and a lot of folks don't understand clinical trials. How was that experience? Why did you decide to get on a clinical trial? What made you sign that consent form? How much was their explanation to you? Just take me through the process of being enrolled in a clinical trial from both of you. I mean, whoever want to take the lead on
It's,
this.
I
Going
think,
to go first.
Shadi, the thing that really drove us to think about it was the thoracic surgeon, because once we knew that we just couldn't have surgery and have it fully excised, something had to be done. It was kind of an alternative to just going straight to chemo or radiation. The other thing
Well,
is,
you have to explain what the clinical trial
I will in
was.
a second. The other thing was when we spoke to you when John was in the hospital 3 weeks after the biopsy, and there was a second lesion. So we knew whatever it was aggressive. And so with the literature, first of all, it was probably not as well explained as it could have been. I had the benefit of the ESMO presentation last year in October of 23 when they published the Nautica 1 trial on the first 9 patients in the cohort. And so that showed very promising results. And I had been working closely with a lung cancer company from Oxford and Zurich. And so, being very tied into that and thinking, okay, this is the trial that John is eligible for. So these results look positive. It is a small cohort, but, can we do this? And so we had the challenge then of understanding that Northwestern had IRB approval since June, and we're now first week of December. And they had not finalized the relationship financially with Roche, Genentech yet. But here we have John as the patient sitting there. So I think they probably moved things into action there. But where it became difficult were all of the checklist of brain MR, PET scan, all of the various things that needed to be done for inclusion in the trial, and the availability of scheduling slots at Northwestern. And it was just like begging, because he has the ICD, to get a brain MR, because they offered us in December an MR scan in April, which, we're seeing the tumor multiply.
So we have to tell two little stories here. One is when I was first diagnosed, my thoracic surgeon said you should consider one of the TKIs. At that time, the TKI that was most relevant was called alectinib, which I'm sure everybody knows now. But alectinib was not FDA approved for me. It wasn't approved for early stage treatment. So I couldn't have it unless I joined a clinical trial. And we had discovered the Nautica clinical trial, and one participating institution was MD Anderson. So again, we're very well connected. We had a connection at MD Anderson, and they, indicated they would
consider John
for,
they would make themselves available for us to go to Houston to be evaluated.
Join their clinical trial. But at the time, we were thinking we'd have to move to Houston, for at least.
So it was open at MD Anderson and Northwestern,
Yes.
but because
Well,
Northwestern was not open yet, but
it was not enrolling yet, and MD Anderson had been enrolling for several years.
Got it. Okay. So, but eventually you actually end up being at Northwestern.
Yeah, they started enrolling, and I am the first and only patient.
So one thing I want to know though is really important. Like, did you, how's the consent form process, the consenting process for the trial? Did they spend enough time with you? Because these consent forms could be 20 pages, 25 pages. You're supposed to read them. And half the time they're not really easily read, even for someone as educated as you are, because now the consent form should read to you like a patient, like you don't have any, you're not a CFO when you're reading this consent form.
Yeah.
So my question is, how much was this explained to you? And I'll tell you why I ask, but I'm curious whether you felt you understood enough about the trial, not from your own reading, from the healthcare team that was explaining things to you.
No, I would say the consent form was treated like every other consent form you sign in the
Sign
hospital.
here.
Sign here. Yeah.
And, you know,
Here's a consent form. Just
Sign and read later,
sign,
right?
exactly.
take a look at it. They're basically waiting for you to sign.
Yeah.
That was it.
And I think,
Yeah.
Shadi, in some element of fairness, I went over, John was hospitalized at this point for, he'd had a CT chest abdomen and had, he went home and exercised. So he thought he was having a cardiac event. And that was when he was admitted after waiting 9 hours and having 62 patients ahead of him.
In the
When I was
emergency room.
in the ER, I'm calling the ER. I was in Philadelphia when this happened, and it's 1 o'clock in the morning, and they tell me, well, yeah, of course he's cardiac, but there's 62 people ahead. So that's an issue to come back to later. But while I was in the hospital for those 3 days, I wanted to maximize that time to understand the consent. So I went over to the office and picked it up, and we read through it. We talked to you about some of the concerns that we had. But in terms of talking to the care team, it was really like, if you want to get this drug, this is the only way to do it because you have to have stage 4 for the FDA to cover it. And we think it would be good for your cancer.
So two things here, though. One is we think it could be good for your cancer. Do you think it's a fair statement? Because if we knew that, then it wouldn't be a clinical trial. Shouldn't they say we have preliminary evidence that it should help, but we are not 100% certain? It's the same thing, but it's framed a
I
little bit
think you
more
could
realistically.
frame it. You could frame it differently. What they had was from 2015 onward, stage 4 data.
Yeah.
And the trial that John is in is evaluating this in the neoadjuvant setting.
Right.
So, as you know, subsequent to him being in the trial, I think it was April or May that FDA gave the approval to use alectinib in early stage. But yes, it could have been explained a bit better. And so we were thinking about it as, okay, what we understood, there was a consolidation before surgery. So if we can use this drug for those 12 weeks or so before surgery, then it does this function like managing the control center of the cancer. And can we reduce it?
Now, I would say, Shadi, first of all, I think we had talked to you. You were one of our many resources. And we had also talked to my thoracic surgeon who had suggested originally that we should strongly consider it. So we learned by the time we got to the consent, and then we started reading. By the time we got to the consent, we had already decided this was a great idea, and we had confirmed that again talking to you. So we didn't really treat the consent as the care team didn't do much to explain the consent.
Did you worry about being the first patient enrolled at Northwestern?
Not at all, because what I feel like is that they're getting the information from the trial, and they have 20 other participating institutions, and they have the sponsor. So the fact that, in Northwestern, again, you trained there, they have, a glittering roster of oncologists.
What would you tell listeners about clinical trials?
I would say, first of all, we did this because it was the only way to get the drug at that time. And so this, as I understood it, Heather can correct me if I'm wrong, I was pre-surgery in the standard of care at that point, I would have had chemotherapy to shrink the tumor and then excise the tumor. In this case, I had the TKI instead of chemotherapy. And there are some issues with the TKI with side effects and so forth. But the TKI was incredibly effective. It basically wiped out the tumor.
Wiped out the tumor. You still had to have surgery.
We actually had so wiped out the tumor that I had asked the surgeon whether we really still needed surgery. And his conclusion was yes, because we can't be certain that all the microscopic particles, are not still there, and your lymph nodes are still worrisome. So we should go ahead with the surgery. But by the time you're asking about the consent, by the time we got to signing the consent, we had already made up our minds that this was
the trial you want to be on.
This was a good thing to do.
But I think we made up our minds more from external sources than
Yes.
actually an
No,
explanation
absolutely.
of the consent.
Yeah.
Yeah. I mean, that's the thing. I mean, I think that, you obviously are very resourceful, and if you put on the hat of a patient who doesn't have that many resources,
yes.
They really have to rely on the healthcare team that they're seeing to explain these things. Maybe in your situation, the team felt enough that they can spend less time, but it's hard to tell.
Yeah.
Yeah. So then you had surgery, and after surgery, the plan was to get chemotherapy, and then you get back on alectinib.
Yeah.
Correct.
Throughout the being on clinical trial, whether it is pre or post, there's so many tests that need to be done, so many blood work needs to be done, visits and things like this. Are these burdensome? Did you have the proper communication back and forth, when to do things, when to do the blood work? I know there are certain situations where it wasn't really ideal, but let's talk about communication a little bit, because I think a lot of folks struggle with access to their doctors, especially at time of need.
That's a very good one. The access is difficult. And then also, Shadi, because they didn't set up this trial, either the sponsor didn't use a metadata platform. So everything is handwritten and it's communicated via, a phone message or a MyChart message. So maybe the protocol changed and they want to have an EKG, and it's, oh, you left already. Can you come back and do this? Or, oh, now we have to add this lab on 2 weeks from Tuesday. So we had a lot of that. And I think that comes from being probably the only patient at the institution in the trial. So you're not really focused on it every day. But the communication was difficult. And then access has been incredibly difficult.
So let's do communication first. From your perspective, what is the ideal scenario? I mean, like how do you communicate right now with your doctor when you need to reach them? How do you reach them? If you need to have a question today.
Schedule an appointment. To be honest, we schedule an appointment.
Yes, Shadi.
Can you email? Can you text? Can you send a note through MyChart on electronic health records?
I mean, the basic answer is no.
You do have those things available, but generative AI as a chatbot would probably return a more comprehensive answer than whomever is opening the doctor's MyChart to respond. Because
why? Tell me why.
Because there's such an inconsistency. So they don't know you as a patient. They don't know you're in a trial.
They don't know you as a person.
They don't know you as a person. They're just, it's on the to-do list to open the chart and answer the messages. And
the answer is coming from a nurse, not from the doctor.
Yeah.
The doctor doesn't even see the messages.
Which is different because thoracic surgery, I mean, the phone would ring at 9 o'clock at night.
But can you give me an example? Can you give me an example of a question you had where you struggled getting the answer? You said, like, I wish there was a chatbot. Do you remember something?
Well, most recently, Shadi, at Jon's, for your listener, Jon went through the surgery, the chemotherapy 4 cycles, and he's now in the 3rd month of alectinib. 30 days after alectinib, he had the chest abdomen CT, and there was a liver finding. He's never had a liver issue before. So he was concerned, sent a note in MyChart and asked if the oncologist could check in with him that day. Now, he had an appointment 2 days later, but this has already been 5 days since the scan. And the answer that came back was, oh, the appointments are all booked. Your concerns can be addressed at your appointment. And so that was, is very off-putting and very dismissive, where you can write chatbots to have some form of empathy.
Yeah. Well, then another example is um, we had the latest scan. There were liver issues, and we had the labs, and there were liver issues in the labs, and we were waiting for what I would consider the obligatory call that we would hope to get, which would be, I looked at this and I don't feel there's anything to worry about. But we didn't know that because there were definite, issues. And so the doctor, so we wanted to schedule a televisit because we're down in Lexington, our doctor's in Chicago. We wanted to schedule a televisit. And the answer came back. The only time the doctor had is Wednesday afternoon. And I said, well, I can't do Wednesday afternoon. I teach. My teaching schedule is reduced because of my medical condition. The university has been very generous. But I teach Wednesday afternoon, and I just can't give up classes. And I said I can do anytime Tuesday, anytime Thursday, and anytime Friday. Just name a time. And it took us
2 weeks.
2 weeks and back and forth. And we kept getting questions of, well, how about 3 o'clock Wednesday? And I was like, no, I just said I can't do Wednesday, and so eventually, after back and forth several times, we got an appointment on a Friday, but we had to wait 2 weeks to actually talk to the doctor.
How much do you think this is a real problem across everywhere in healthcare versus the institution that you're at? I mean, do you think this is the same issue?
I think it's healthcare.
I think it's healthcare.
But it's also the burden of care that the physician feels toward their patient, because we've all been on the side of waiting for a result. And, as the physician, if I could call someone and alleviate their concern, it takes 5 minutes of my time.
Mm-hmm.
That was the way that I practiced medicine.
So that's my question. How do we know if it's not,
I think it's physician dependent, Shadi.
Right.
Because within the same institution, it's varied greatly.
Well, when my surgeon, and Heather mentioned this, the thoracic surgeon that did my surgery, followed up,
Right.
of course, the obligatory day after the surgery or whatever it is, right after the surgery. But I had some complications, and I stayed a couple of extra days in the hospital, and he came every day. And he came on the weekends, and he wasn't dressed in his white coat. He, clearly made a point of, taking time out of his day on Saturday to come in and check on me.
Well, that's wonderful. That's really amazing. That's the human element of being a doctor.
Yeah.
Mm-hmm.
Yeah.
But I want to go back to this. I mean, having to wait 2 weeks just to get reassurance about some abnormality on a scan or something like this seems to me too long, because the doctor could pick up the phone and discuss this on the phone, but they wouldn't do that. I'm a bit surprised about this.
The nurse sent a note through my chart. Well, if you can't make this appointment, this is her first available. Oh, she says that the scan looks fine. But that doesn't answer the question of, Shadi, we're looking at elevated labs. How elevated should bilirubin and liver enzymes and alk phosphate? How elevated is too elevated? When do we need to think about, is there potentially a dose reduction, or is there a holding to allow, the liver to recalibrate? These are the things that in my mind, from the clinical trial standpoint, I'd like to know, what are the milestones for the institution that they have to meet for the certain payments that they receive? Because there's almost if we can get you to the 90 days and not have to answer this question, and you're not critical, but is it double? Is it quadruple? What are the abnormal labs? And those are the things where it would be helpful just to have some kind of care navigation. Okay, your lab's elevated, but we're not worried about it right now.
Yeah, I mean, so we got the lab results through my chart, and I'm not a doctor, but I'm an intelligent person. And the lab results will say, the range of normal for bilirubin is something to something, and I'm over it by, 20%. And then there are some other liver things as well, and I was above normal on all of those. And so that, gets me nervous about, what does this mean? Is this meaningful? Is this something I, need to take action, or what? And I was hoping to get the call that we actually had was exactly what I was hoping for, which was she carefully went through each one of the lab results and said, yes, this is a little elevated, but it's not concerning to me because of blank, which was great. We were on the phone 13 minutes. And, if we had had that call 2 weeks earlier, we would have been greatly reassured.
Well, that's the thing. I struggle with the idea that we cannot find time for a 13 to 15-minute phone call in 2 weeks. I have issues with that, to be honest.
Yeah. Well, and Shadi, again, I'm married to a doctor. Heather used to it being a practice with a number of internists. And from what I can tell, the internists are the most overworked doctors around. And yet I know, and we got Heather's, because she shared an office with them. She was very close friends with them. And when I would go in to see the internist, at one point he mentioned to me, oh, I'm going to see you at 4 o'clock because I'm returning calls all night to my patients. I got a call list here that I have to return to patients. And I think that's just,
kind of lost. It's lost when you get into institutionalized medicine and maybe some academic medicine. The other thing, Shadi, is the side effects. And one of the things that is so critical about these drugs is they're not without side effects. Some of them are far more serious than others, but the side effect journey is something that you have to discover on your own. You have 50 pages of potential side effects, but it would be really helpful. The only thing that we heard for side effects is, oh, some people have ankle swelling. And Jon's had a lot of different side effects. And granted, he's not had pneumonitis. He hasn't had things, he hasn't had the worst he could have, but he's had side effects that have impacted the quality of life. And there's never really been a way, I suppose there wasn't ever an explanation. It was just kind of like, here's your pamphlet of your 50 pages of what could go wrong.
Yeah.
Yeah. And I think what also, we have continually asked, is there a pattern? Is this a situation where you have side effect A and it will gradually get better over 3 months or 6 months? Just tell me what what the evidence has been with all the other people who have been on Alectinib. And then the other thing we've discovered is I get new side effects all the time. I had a new side effect this morning.
But when you get these side effects, when you get whatever side effect is, new or old, reported or not, I'm still having issues that you cannot discuss that for 2 to 3 weeks with people because you have a side effect this morning.
Yeah.
It can't be the choices. You either go to the emergency room and wait for 10 hours in the emergency room, or there should be a happy medium. Like, did you call anybody about it today?
Well, so here's what we do. Heather, one of Heather's best friends is an emergency room physician. So this is at 5:30 or so in the morning, and Heather sends a text to her friend to say, what should we do? What do you think about this? And so that's what you do, but it's just been very difficult.
But most people don't have Heather. That's the thing.
I know.
But Shadi, what's happened is with the side effects, one thing that's been very problematic with Jon's oncologist at Northwestern is the times that I've had to call when, the fever spiked 5 degrees in 30 minutes in chemo and we suspected pneumonia or neutropenic fever. There was the answering service, after having you spell your name 3 times, they said to me in December and then again in May when this happened that they didn't have this particular physician. So they actually asked me if I was confused. They understood that cancer can be a complicated thing. Maybe I've called the wrong place.
Wait. Let me unpack this a little bit. So you called and they thought you pretty much
Weekend coverage
crazy.
number. We call it the weekend
Well, they thought
coverage
I was
number.
confused. And
Yeah.
this is the number. And you know, Shadi, thank God there is one dear soul at the front desk who saw how distressed we were when Jon was initially coming in as a patient, and she gave me her number to her phone at the desk. And so that's the only way I've been able to bypass the 45-minute hold that you get when you call the oncology department. And on the weekend, when the answering service answers, they don't have the doctor twice. So once was between Christmas and New Year's, the other was the second week of May.
Who do they
And
have? Who do they have?
well, I finally said, just give me the on-call physician. And I had to say, I'm a physician. I want to talk to the on-call physician because they wanted to ensure that they had pulled the patient record. But they've now told me that his doctor doesn't exist. So twice we were there. The recommendation was to go to the ER. And when you go to the ER as an oncology patient, they look at you like, oh, well, if you're not truly dying, we'll stabilize you, and then you should see your oncologist.
They basically won't treat you.
Well,
I mean, they'll treat
they'll
you. I'm
treat
sure
you.
if I was dying, or if I'd been shot in a robbery and I was dying of a gunshot wound, I'm sure they treat me. But when you go in, I was going in because I woke up in the morning. I was on chemotherapy. We had lots of side effects with chemotherapy, platinum-based chemotherapy. And I had a sudden
He had
ridiculous
rigors
spike in my
and the
body
fever.
temperature to the point, and it was escalating. We checked it at
Well, that
7
was
a.m. and it's 100, at 7:30 a.m. and it's 102, and we're worried about, boy, what if this goes up, to
oh,
very dangerous levels? What should we be doing? So that led to calling the coverage number, and we finally got a doctor. He said, well, I have to have somebody take your temperature, somebody official. So you have to go to ER. And so we go to ER. We actually got in relatively quickly, only
that's what happens when you
short
go
wait.
at 6 a.m. on a Saturday morning.
Yeah.
Right.
But we spent the whole day. We were there the entire day from 6 a.m. to 3:30 on a beautiful spring day. We spent our entire day in the emergency room. They were very nice. They did a lot of tests, but the end result was they didn't want to do anything. They didn't think I was in any danger. And as a result, they didn't want to do anything because they saw I was being treated for cancer. I had an oncologist, and they recognized that it was a very, fragile balance in terms of my
Well,
medical care. And they basically said, basically your choice is we can admit you for observation, but frankly, you're well off. Your wife is very able to take care of you. You'd be better to go home and wait till you can go Monday. And if something happens, come back.
and Jon had pneumonia, so he had consolidation in the middle lobe, and they started him on Augmentin IV, and then we went home with a prescription. But then the oncology structure is such that they have an urgent care, but it only operates Monday to Friday during office hours, and you need an appointment to go to urgent care. So
Yeah.
that's separate from the oncology office.
So in the last 10 minutes, what I'm struggling with is that we have made a lot of advances in how we treat cancer. Obviously, I mean, it's an example, and that's why, you underwent sequencing, you had the ALK positive disease, you received therapy specifically target this mutation. Hopefully, the outcome will be complete cure, and that's what we are hoping for. But essentially, that's an example of significant advances in the treatment. You've had a very successful surgery with a competent surgeon. That's an example of, again, advancement in surgical technique and things like that. It seems to me that we have made zero progress, if not backwards, in the way we deliver care, in what I call healthcare delivery. And healthcare delivery goes from literally anything that you go through. I mean, again, from literally communication, education, enrollment in clinical trials processes, things of that nature. My two questions is, A, am I correct in that assumption, or am I being too harsh? And B, we live in the era of innovation in technology, and obviously Heather is heavily involved in this. And I think from where you are, Jon, you obviously have probably been exposed to a lot of innovative companies and things of that nature. What are we doing wrong? Why are we not improving fast in that process? I can literally go on my Amazon app and order the Cancer Journey book, of course, because everybody has to order that book. And I could possibly get that book in less than 12 hours at my doorstep. Yet, it's like what you went through, there's so much. Sorry for the verbose question, but help me understand this, and what's the path forward? Like, how do we actually improve that? Because I promise you that you are not alone. I also promise you that, believe it or not, your experience, as dreadful as it is from the delivery aspect, is probably better than 90% of other people. So imagine that.
Yeah, that's sad to hear. I think, first of all, I couldn't agree with you more. We recognize that, from my perspective as a patient, we're living in a brand new world that is remarkably improved from, 10 years ago even, much less 20 years ago. And, we're blessed to be, living here today in 2024. I think where this has fallen down is in the very mundane area that doesn't require great technology, and that is in communication and coordination. There's just no real coordination. One of our other things that we would point out is when we have a problem and we need another doctor, not an oncologist, we need a gastroenterologist. And gastroenterologist. The reaction from our oncologist is, oh, you should consult your blank.
Basically, you should go find one.
You should go find one. And then when you go find one, so I go to my urologist, for example, who's treated me for decades. But, he's not an expert in oncology, so he has to circle back to the oncologist. After I leave his office, he has to connect with the oncologist to make sure that he understands exactly what, he wants to do and how it coordinates with what she's doing, et cetera. But there's no, so the simplest thing would be a live human being called, a patient care coordinator that would take all this off my plate. If I need another doctor, and I don't have one, just get me an appointment. Because now when I get my own appointment, the first appointment is usually, 4 months out.
That's if you're lucky.
And, and if you had a care coordinator that could go to the whatever other doctor you needed, make the appointment, get it set up, make sure they understand it's a priority, it would make a difference. But
yeah,
the non-technical, simple stuff is the stuff where the system's falling down.
But is there a chance, Heather, for innovation here? Is there a chance? You mentioned chatbot, which piqued my interest, right? Because that essentially
Generative
innovation.
AI.
Right, but it is
How do you
new technology.
Can you scan the patient record so whomever opens the chart has a summary about this patient rather than just seeing the message? So they have some context to answer the question. And then a lot of these additional what John just described with needing another provider. It comes from a side effect of the drug. We were fortunate that he has the ICD because bradycardia is a side effect of alectinib, and John's had blood pressure that's 90/60. And so we're protected in that aspect. We have a cardiologist, but if you're a patient who doesn't, and you suddenly are dizzy with blood pressure that's low, are you left to your own devices to try to get into the cardiology pathway to have someone take care of you, or do you have to go through the ER? That's where this coordination, and then also you can use AI from the medical record standpoint to flag these things. If you're using like an Apple Watch, or you're using a sensor that feeds into your MyChart, then your doctor can be alerted. But the care coordination is really lacking right now. And we have a clinical trial coordinator, but again, John's the only patient in the trial, and she's been helpful when we've reached out.
Are there opportunities using technology for clinical trial operations and execution, in your opinion? Like anything that
Absolutely. I
what
mean,
have you encountered where you wish that there was some automation or some changes?
so the journaling every day, and this exists, it's just that this trial didn't choose to participate in it. So this is the metadata rave platform where you could go into your iPhone and you could take a picture, of your side effect. Maybe you broke out in a rash, or you can put your entries in every day. And so it consolidates that, and you don't have to keep a paper journal.
And
Also, the
I would
changes in
just say
protocol.
also, just to interrupt you for 1 second, a lot of times all you want is reassurance, that I'm having a side effect. For instance, alectinib is known to cause sun sensitivity and rashes. And I was and so I've been trying to figure out how long can you be in the sun. Originally, in the first few weeks, I could be in the sun an hour. I could read my book and lie in the sun for an hour. Now it's gotten to the point where it's 5 minutes. 5 minutes, my skin feels like it's burning. I don't have a red burn, but my skin feels like it. And it would, so it would be nice to be able to be reassured by somebody. Well, that's a common side effect. There's and by the way, I put on, I'm olive complected. I never burn. And been putting on 70 SPF. It doesn't do any good. It would be nice to just be able to get somebody that said, oh, this is a common side effect. Yes, you really can't rely on SPFs. You have to just wear a big hat.
Yeah.
Which I do.
And
Well,
Shadi,
yeah.
it would be nice also when there are changes. So, if an EKG is added, or if labs are added, or there's a new frequency, or you need to get an MRI, if you were able to have that communicated somehow electronically so that it's part of the trial information as opposed to just a here and there MyChart, because then it becomes a little bit discoordinated. And I think I'm probably a very type A person, so I like to understand, here's what we're doing at 30 days, at 90 days, at 120 days. This is when we need to schedule the PET scan. These are the scans that we need. And it helps, I think, to have a sense of normalcy to be able to plan that out rather than sort of an ad hoc. So I'm the one who's asking, when's the next one? What's the next thing to do? And that's not always easy to get.
I'm hoping that innovation is going to change and improve this. There's so much work that we could do, and there's so many smart people out there, so many companies out there, and hopefully things will get better. Is there anything that I should have asked you that I completely forgot that you think might help listeners and viewers get more insight into what you went through that might really translate into them having a better experience, or at least alert them to the experience they may have?
Do you want to talk about when you had my scanned by the AI company, Uptell?
Yeah, Shadi, one thing I think we should probably have a separate conversation on is the AI in medical imaging, because I took John's 3 scans, and they were scanned by a company that specializes in lung nodules and assigning a probability of malignancy. And this is an interesting company because it's purely based on incidental findings, and these are PACS reports. So patient came in for something entirely different.
Yeah.
And the probability of malignancy was an 8 on the first scan, and it didn't change. And so if we had known when it was first identified that it was an 8, then
Means 80% likelihood of malignancy.
and this is what happens is the AI lives in the PACS and it runs on NLP. It mines the reports every 24 hours. It pulls out those incidental findings. It cuts the pixels and it sends those to run against the biopsy confirmed database that was built at Oxford. And that then returns you 2 hours later your probability of malignancy. So if you think about a European train schedule, how it's constantly moving, that becomes the nurse navigator dashboard in a lung cancer screening program, because these are the patients that you don't know are at risk. These are your incidentals, and you can merge them with your known risk. And then you're going to populate who really needs to have a biopsy, because one of the things that's always brought up is we're afraid we're over biopsying. This is a way that you can be certain that you're biopsying those needed patients.
Well, and just to maybe overdo the point, at the point in my journey where we weren't certain whether this nodule was cancerous, that scan Heather sent to this company for them to run through their system. And, they gave us all the appropriate disclaimers. I'm not a patient, et cetera. They're doing it for Heather as a friend and colleague. And it came back. So this was at the point where I was in observation mode and denial. And this came back saying 80% chance of malignancy. Well, that would have changed our whole approach.
Yeah.
And had I had a segmentectomy, so go back to my first what could go wrong question. Had I had a segmentectomy, you know more than I do about this. My view would be it would have been surgical, it would have taken out, there would have been clean margins, and that might have been the end of the entire process. And there might not have been any chemotherapy and certainly no alectinib, but my life would have been dramatically different than what I've gone through.
I think we don't know, but I see I see what you're saying. We don't know how different would have been, but I think going back to your most important point, which is there was an opportunity to deal with this earlier.
Yes.
Have we applied some form of technology
Yes.
and things of that nature?
Yeah.
I'm really very grateful for you sharing the story. I think that it's not easy always to talk about the personal journey, and I think you were very, very open about it. I've learned a lot, which is how much we need to do on the healthcare delivery process, on the communication process, on the response, on the patient-centered aspect. I feel we have focused so much on drug development, which is great, but I just feel we should also focus on additional aspect that is intimately affecting the journey of patients and families.
Yeah, Shadi, I'll try to get this out. I'd want your listeners to know that you're not just a voice coming in over the internet. You've been my guardian angel.
Oh,
this process.
Yeah, no need. I'm glad that you're able to share the story and tell people about it. And Heather, there's a chapter for you in the book. As you know, I told you have to read that chapter.
I read that chapter.
It's called Caring for the Caregiver.
That's the thing that none of these programs do. There is, from the health economic standpoint, they send you questionnaires to ask if you're concerned about having housing or shelter or food. But I think the mental health, as long as they feel like you're not going to commit suicide, you're okay on your own. And that's directed to the patient, but there's never anything directed to the caregiver, and there are no resources as part of the structured delivery of care.
Yeah, I saw this so much in my practice that I just had to do. I dedicated an entire chapter for it, and I told you have to read it, the first chapter to read, because
I did.
well, I hope it spoke to you, because I just think it's a lot of people deal with this.
No, and I think the way you described it was very eloquent, because you talked about your experience and the empathy that you had for the caregiver when you were practicing, and how, you wanted to ensure that they could go back to work and you would take care of their loved one and you'd give them updates. And
Right.
that's so important, to have the level of trust that you established with your patients that way.
Yeah.
Um, because this becomes an all-consuming family issue. And then also it's you, at what point do you have to continue to work and provide for your family versus take all the time off to be the caregiver or the patient?
Yeah. Well,
So
John and Heather, thank you so much for coming on Healthcare Unfiltered, and let's just get rid of this cancer forever.
that would
Cancer
be good.
sucks, and it's Healthcare Unfiltered, so I could say fuck cancer. There you go.
Yes.
Thank you, Shadi.
Thank you,
Nice
Shannon.
to see you.
Good to see you.